Welcome everybody to the Hypertrophic Cardiomyopathy Association's Facebook page and our series of Meeting the Experts. And today we're going to meet a new Center of Excellence. So I'm going to give you a few seconds here to populate so that you can join us as our new guest joins us in just a few moments. As a reminder, the HCMA is conducting a number of different interview programs on this Facebook page now, including Meet Our New Centers of Excellence, Meet the Experts, and Share Your Story. If you're interested in sharing your story with hypertrophic cardiomyopathy on Facebook, so it will also be then shared on our YouTube channel and website, please contact us at support@4hcm.org and just note share your story in the reference line, and we will be getting back in touch with you. So we've had some people join us now, and without further ado, I'm going to introduce my partner here today, which is Dr. Srihari Naidu, and he is with Westchester Medical Center. And I am happy to say that Westchester Medical is our newest Hypertrophic Cardiomyopathy Association recognized Center of Excellence. Dr. Naidu, welcome to the Facebook page.
Thank you. This is wonderful. Thanks for having me.
Absolutely. So why don't you tell us a little bit about yourself?
All right. So I'm here at Westchester Medical Center, but before that I did my undergraduate in medical school at Brown University in Providence. Then I spent some time at Cornell in Manhattan for residency, followed by the University of Pennsylvania for cardiology. And it was there that I gained some interest in hypertrophic cardiomyopathy and heart failure in general. I also trained in interventional cardiology. My first job after that was back at Cornell, where I trained in residency to be an attending. I think that's where I met you, Lisa, briefly. And then from there, I went to Long Island to run a hypertrophic cardiomyopathy center at Winthrop Hospital for about 10 years. And that's where we also got to know each other even more. And I'm very proud of how far the program went at that point. But then about a year and a half ago, we moved to Westchester to really make a very strong, comprehensive program in the manner that that you have always told me is the best way. And so I think we're very proud of what's going on here.
I would agree with that. So why don't you tell us a little bit about this new team that you have up in Westchester?
So, you know, I thought long and hard about how a HCM program should be perfect. And there's nothing perfect, but perfect is a work in progress that you're constantly trying to improve upon. You know, at other institutions that I was at formerly, one of the challenges was that it's hard to get a true team where everybody is not just participating in the care of patients, but truly becoming experts in that care. That requires volume, that requires a certain amount of training, and that requires a commitment of the institution and the individual doctors and all support staff towards this vision of a program where from soup to nuts everything can be offered. So here at Westchester, we have some of the components that I think are fairly rare. We have heart transplantation. We have the full complement of pediatric services, including defibrillators and surgery. We have a geneticist on staff who works with the program in addition to genetic counselors. And we have both invasive options, the alcohol ablation and the surgical myectomy, which I know we all feel strongly are both important for this population. And so that when you take all of those together, it allows for a patient to come seamlessly through a program. And no matter what they need, if you're not sure of the diagnosis, or you're not sure of exactly what's the physiology, or you're not sure what's the best way to treat the patient, you can do all the studies and get all the proper opinions to make a much more informed decision with the patient. And that's the vision of this program. And it really is to be patient-centric and to be high quality and multiple touch points with the patient.
So you have an interesting dynamic that kind of goes back into my history with HCM at your new program, and that's your department chair.
Right.
And why don't you tell us a little bit about who that is and what his history with HCM is?
Right. So my chief is probably the main reason I came here, in addition to other individuals who I've trained with for a long time. The electrophysiologist, the heart failure specialist I've known for over 20 years, but Dr. Panza is special. So when I looked at places to go, I met with Dr. Panza about maybe 6 months before coming here, and I realized that he is, first of all, extremely good clinician and researcher, but has a very distinct history in hypertrophic cardiomyopathy. And I have never been at a place where somebody knows and understands hypertrophic cardiomyopathy and the nuances of these patient population before. And Dr. Panza trained at the NIH, where he was the director of the Echo Lab, at a time when hypertrophic cardiomyopathy was really burgeoning, and a time where most, if not all, patients around the country that had this disease was shuttled through there with Dr. Barry Marin. And so he actually provides a very unique perspective that provides some of the history that I was missing. And so I see how things have been the last 15 years, but he sees how things had been the last 30 years. And together, I think there's a much more respect for the disease, and I've learned a lot about what has happened before so we don't make the same mistakes again. But also what things maybe we could try again, or maybe we can look at the whole picture and see where the field may have to go. So he's been a breath of fresh air. He's been very supportive of the program and this team approach. And in addition, he has also been very supportive in seeing patients. And when I'm not available or not around, or even to bounce ideas off of. He is part of the HCM team meetings we have to discuss the myectomies or the alcohol ablations and any complicated cases. And his knowledge of echocardiography is amazing.
Yes, from the personal side, he and I had crossed paths back around 1988-ish, 89-ish, and it's nice to kind of circle it back around again and find some of these people are still interested, and we're just hiding in places that I didn't see them for a while.
In 1988, I think I was riding my motorcycle around Long Island back then.
Thanks, Hari. Needed
Well,
that.
med school, yeah.
Okay. So you've got a comprehensive team. We've got everything from surgery to EP to pediatrics, genetics. We've got the whole system there. You mentioned your team meetings. Why don't you tell us a little bit about how your team meetings are run?
Yeah, the team meetings are great. So the people I want to introduce, number one is Mallory O'Shea. She's our HCM coordinator, and Nicole Goldman is our Long Island HCM coordinator. So as you can already surmise, we have a large program that spans multiple regions, and we're very patient-centric in that patients can access the program in a number of ways. The team meetings are run by myself with Mallory and Carolyn from surgery, and the surgeons, the echo physicians, myself, many of us all get together and we talk about each of the patients, particularly the ones that have challenging situations. Certainly the ones that need potential myectomy or alcohol ablation, but also the patients where I'm just not sure exactly what direction we should go. So those meetings happen monthly on a Tuesday morning, where we meet actually in this room, and I present the cases that I need their opinion on, and we come to decisions. Typically, we try to tag team these meetings or stage them in relation to patient visits. So we have patients coming from all over the country, and we try to stage these meetings so that we can come up with an informed decision of our unified opinion on the patient prior to their arrival. Or between their visits. So that meeting has been very helpful because each of us looks at the patient from a different vantage point. And I have experience in terms of just sort of what I've seen patients do and how they've progressed, but they may have different opinions on what might be options for them. And so that gets integrated into a nice discussion for them.
Fantastic. So both as a team and individually yourself, what do you see are the challenges for hypertrophic cardiomyopathy management?
Right. So I think the challenging part of HCM really is that each patient is very different. Each patient is unique. What I find most fascinating is trying to understand how each patient's disease is manifesting in them. And I think that's the trickiest part. Each person you can look on paper and they all have diastolic dysfunction. They may have regurgitation or atrial fibrillation, pulmonary hypertension, but each patient's a little different in terms of what of those are really contributing to their symptoms and what are their symptoms, and digging those out. So the most challenging part of hypertrophic cardiomyopathy is that for me, because once you can figure that out, then you can be very precise in determining a stepwise approach to making them feel better. So that's what I find to be most interesting and challenging for hypertrophic cardiomyopathy. I think that is also why it's important to have a center of excellence, because you cannot begin to do that unless you've seen hundreds, if not thousands, of patients. Otherwise, you will just sort of treat each patient the same until they fool you or until they surprise you. So you want to minimize the surprises by being able to predict as much as possible, and that's what we try to do.
Yeah, we definitely like to keep the surprises to a limit.
Right.
Yeah. We know that it can get us sometimes, but we try to stay in front of it. So are there any particular areas of research interest for yourself or your program?
Yeah, I think as we've expanded the team, there's a variety of areas that I think have come up. My personal interest has been in the invasive therapies. As you know, I've spent a long time investigating the appropriate role of alcohol septal ablation versus surgical myectomy, and that drama has played out for a long time. I think we're at a good place now, which is that both of these procedures are necessary in the right patient population, and our job is really trying to figure out what will get them the most durable result. And in some cases, it's myectomy if they can, if they're young or healthy and can handle that, or have other reasons for that. And there's other cases, particularly the older patients or patients with comorbidities or particular anatomy where alcohol ablation may get you the same result. So my research has focused on really optimizing patient selection and also optimizing outcomes in alcohol ablation in particular. And then from there, discussing where these should be done. So we talked about center of excellence concept where patients should come to these major programs, of which we need more. But if you think we need more HCM programs in general, there's even a smaller handful of programs that do excellent surgical myectomy and excellent alcohol septal ablation. And as you know, we came out with a paper a couple of years ago looking at volumes across the country, and it was very eye-opening, showing that the vast majority of procedures are being done at very, very low volume hospitals, hospitals that do maybe one every, up to maybe as much as one every 10 years, or two every 10 years, or 5 in 10 years, very minimal compared to the guidelines. And so I've spent a significant time trying to raise awareness about that, and both try to make sure patients are, for any procedures they need for hypertrophic cardiomyopathy, are being seen or being referred outside network if needed to places that can handle these. And then on the other side, I've also been very vocal and instrumental, I think, in trying to teach these techniques, or at least the alcohol ablation technique, to areas, preferably center of excellences under your auspices, that really should have it as one of their armamentariums and to do it right. Going forward, I think it would be nice to have a real national registry on both alcohol ablation and surgical myectomy, and I think there are some changes here that might allow resources to move in that direction, to perhaps have forms that and registries that could be sponsored across the country for both surgical myectomy and alcohol ablation, to really get a handle on, are we doing the right patients for each of these, what are the outcomes, and then we can go back and fine-tune which patients really should get one or the other, and wherever the cards fall is appropriate. But I think that would do a lot to move the needle in terms of making sure that patients have durable results long term.
I agree completely, and coming this spring, the HCMA is convening a meeting of surgical experts to determine best practices for myectomy, to standardize them across the country, and also to discuss the options of how to build a registry to determine not only what alcohol ablation versus myectomy, but within myectomy, what exactly is being done. Are we doing papillary muscles? Are we working the valve? Are we going deep into the cavity? All of those details. Because interestingly, if you've got high volume, the nuances of the procedure don't seem to change outcomes very much, which I'm finding quite interesting. So hopefully we're going to get a little bit more into that. And once we organize that, then maybe we'll open the door on procedural issues related to alcohol septal ablation, those two together, and then we'll have the best answers ever. So there's always stuff going on underneath the surface here.
No, I think you're right. I think the surgical one is important because there are 2 or 3 different types of techniques that people have the best outcomes, and they've been devised independently, and so you have places doing different models. I think in alcohol ablation, several of us have worked very hard to standardize the technique and to roll out best practices. I know certainly at our course we continue to advance what we can do to minimize complications, and we try to make it clear that places around the country should stick by that standard. So I definitely applaud your efforts in the surgical myectomy arena to do the same thing.
We're hoping it'll work out well. The other thing that I'm very interested in working with Westchester on is they have a humongous behavioral health services program. and a great academic outreach there. And I'm hoping that we can tap into some of those resources to help identify more of the mental health needs that are missing right now from the HCM experience. When somebody's diagnosed with cancer, there's a whole myriad of articles about the mental health implications, the anxiety, the stress, the uncertainty, the grieving for the disease process. But there's not a lot of data in HCM, and cardiologists tend to focus on about, oh, this region about here. We need to start thinking about the whole body and the whole person with HCM. So I'm looking forward to your team particularly to maybe help open those doors a little bit more.
I think you're right. There's two things that happen. One is that it is a chronic disease. Whether you feel well or not, it's chronic. I mean, it's going to be with you for the rest of your life. And you're right. The more we do it, one of the problems with centers of excellence is probably that we get numb to it. The fact that we see 1,000 patients, giving them the news of this disease, we may forget that it's a big news for them. Yeah. And so I completely agree with you that on the one hand, the fact that we forget about it means that we're reassuring them that it's not going to hurt them in the immediate future for the vast majority of people, and you can live a normal life, quote unquote. But we shouldn't belittle that. And I agree. Here we have a huge behavioral health services team in the whole area of the campus that can focus on these issues. So I agree that would be a nice area to move into.
I'm hoping to. So now we're talking about a little bit more research-oriented issues. What are your hopes for not only the HCM community, but your program's future? What do you want to see? Best case scenario.
So, I kind of feel like right now we've built a very, very strong program in terms of the clinical aspects, meaning when a patient comes through, right from the beginning, they're met by Mallory. So we have here a situation where we have a dedicated HCM email, a dedicated HCM phone, a text where you can text to as well. You call one number and you get Mallory, basically. When you don't get her, you get Nicole. So you get someone who knows HCM. Mallory's in the office with me. She sees all the patients. So patients don't get lost. Once they're in the system, we organize their visits in a very comprehensive way that's also very efficient for them. So we know what they need. When they come in, they go from echo lab to the office, maybe an MRI, and then they see me, they get the full visit, and they get an opinion that maximizes their time that they've been with me so that it's very efficient. I'd like to see our program develop in a way that it maintains that. It maintains clinically very strong and high volume. But then we develop circles where we move into the community. We do more about awareness nationally. I've always been interested in that, raising awareness, community events, because I think that we're making sure that patients who are educated about this disease and referrers who are educated sent to a center of excellence, but we have to go further than that to make sure that our community is aware so that we're not relying on individual referral relationships or individual patient understanding, but the community, our society as a whole, has figured out that HCM patients need to go to centers of excellence. And just like other diseases that also have a lot of outreach and have done very well with that, HCM is actually far more common than many other diseases. And it's not a competition, but rather we need to be at the same level so that we can catch as many patients as possible. So I'd like to see our program move in that direction with more community events, more national broadcasting type events to raise awareness about HCM so that the funnel is much larger and patients end up at the right center, which thankfully there are many more nowadays than there were before.
Right now there's, by the end of the month, there'll be 31. So it's still a small community, but much larger than the 3 or 4 that we had 20 years ago. So that's a good thing. And I am going to put a teaser out there that I am working on something that I can't disclose yet, but may make us pop to a whole different level of awareness. So stay tuned for more information on that. But it's going to be really cool, I hope. So we're working on that one. So let's dig in a little bit more on the issues that you just brought up, and that is, how do we make sure people get to care? Is it really a question of community outreach, or is it an issue that we need to work with the payers on? Payers understood that it's much more cost effective to be treated within an HCM center of excellence, so you're not getting an inappropriate cath or CT scans when you don't need them, or other therapies and treatments and diagnostic tools that don't really have a lot of utility wouldn't it be better for them as the payer community to send patients directly into a center of excellence where we're not going to waste resources?
I think you're absolutely right. I think we have to do that documentation and the math and show that. Just off the top of my head, places that don't do this as much, they oftentimes will put defibrillators in more often. Yep. Patients may get electrophysiology testing, which is not very sensitive or specific for problems, and it exposes patients to risk. They certainly are not doing as good a job of being as comprehensive. Many patients today still come after at least 5 to 10 years of being under the care of a non-HCM specialist, and typically many things happen during that time. One is that they progress. They progress in very salient ways that are not so obvious, and they end up in more congestive heart failure than they would have been, and they were not treated as early. Many physicians feel it's just beta blockers for as long as a patient can tolerate, and that might just be too late. And you're right, the imaging. If we know which patients need MRI, which is probably the majority, but don't need CAT scans, for example, or if they have chest pain, some of it we know in a young person what it is. They may not need an angiogram, they may just need a CTA, or they may not need either. You might try medical therapy first because you by and large know what that is. So I agree with you. I think if we culled the data from the variety, from all the centers of excellence on the average kind of quote unquote cost per patient that comes in for the first year, for example, or when you define when diagnosis has been met and the first sudden death assessment has been done, you add up those costs and then look at what's happened to other places. Maybe that would be a good way to pitch to the insurance companies, which are national, many of them, and they may therefore allow us to cross state lines to take care of their patients.
So I think that is an area that we need to start looking at more closely going forward.
We'd be happy to work with you because we're getting more and more patients from all over the country, and we're dealing with these issues on a daily, at least weekly basis, where patients are coming from other states, and we try to make that value proposition to the insurance companies as well.
Yeah, we'll get there eventually. Fingers crossed. In a few moments, we're going to take some questions from any of the viewers who happen to be catching this live. If you're watching a repeat of this broadcast, which is actually 1:30 Eastern Time on February 5th, we will try to respond to your comments or questions as you post them on the HCMA page coming forward. So we're gonna pivot here a little bit. So we've talked a little bit about your clinical background, your education, the center, but who are you? What do you do when you're not working?
I have a lot of hobbies. I won't share them all with you here, but my main one, obviously, family. I have a young boy. He's, most fun thing that I do when I'm not at work, spending time with him. But the other big hobby is I'm a big NBA fan. So I have Knicks season tickets. I watch them all the time. I know they're not doing very well, but it's still fun to watch all the visiting teams. So I was there yesterday before the Super Bowl, where they lost, unfortunately.
There was a game yesterday?
There was a game. I know. So, yeah, I'm a big NBA fan, and I like to exercise regularly throughout the week. So those are my main hobbies. I have there's one last hobby. It's usually bothering this woman named Lisa Sahlberg at least once a week. I'm really good at it.
He's really good at it. You see, there's this thing called text messaging. Should not have given him that number. It's
a great hobby, too. I highly recommend it to anybody watching. Bothering Lisa Sahlberg, great hobby.
Well, he started this hobby about 11, 12 years ago at the American College of Cardiology. Yes, I'm going to tell the story.
Yes, you are.
So this young doc comes over to the booth and, trade show type booth out on the exhibit floor, and he said, I'm interested in hypertrophic cardiomyopathy. I'm going to really get good at this alcohol septal ablation thing, and I want to see more of these patients. I'm like, okay, well, that's great. You can call my office and we'll talk. And then he kept talking. And he stayed for about an hour and a half. And then we walked to talk together. And I'm like, okay, I have to go now. There was one thing I can definitely say about Srihari Naidu. The boy does not lack passion. He's a very passionate physician, and he cares very deeply about hypertrophic cardiomyopathy. Sometimes it's a little unbridled enthusiasm, and I'm actually the one kind of saying, okay, take it down a notch.
Yeah, because you're so calm, and you don't move fast at all.
That's really unusual. Okay, boys and girls, we're going to take some questions from the audience now. If anybody has any, you can ask any specific question about hypertrophic cardiomyopathy or the program at Westchester, but we can't give individual medical advice. So if there's any general questions, we'll take those in a moment. So I was just up with you guys this weekend or Friday at the symposium for nurses. And I brought with me, it's actually the first time she's been out and about, my true anatomic heart. I have to say, that was quite a teaching tool.
Everybody wanted to see it.
Everybody wanted to see it.
Very cool.
And the thing that threw me the most about that experience, and I mean, it's the first time like complete strangers are like literally looking inside of my body, which is a little strange, I have to admit, but how everybody thought that an HCM heart was going to be enormous and big. And my heart is the size of a normal heart on the outside, but when you open it up, it's all muscle. And that I found fascinating, that people didn't think it was HCM because it wasn't this way big. It was muscle big. So, kind of strange.
No, that's a great teaching tool, because people think that if it gets bigger, it's getting bigger, bigger, bigger. But really, these hearts stay the same. They're getting, the room inside is getting smaller, smaller, smaller. And actually, that's very, very visually, the messaging is very on point with that. Basically, you have the heart is of a child compared to what it should be for an adult.
It didn't have enough to service all of this. Well, we're getting off lucky today in a sense, or everybody's too busy working and trying to watch us and not let their boss know that they're watching Facebook during work, because I'm getting a lot of questions today. So we do have a couple people that are visiting. I think some patients here. Kathy's here, and she just wanted to let them know she was here.
Hi, Kathy.
Is that your Mallory?
Oh, that is Mallory, yes.
I guess she sent a symbol, but the symbol didn't take. Yes, it is Mallory.
Thumbs up.
And Stephanie. And I don't, is that a flower? Did she send us flowers? She sent
a basketball.
A basketball. Oh, is that a basketball? Think how much I know? I thought it was a flower. Oh, hi, Deb. We just spoke a little earlier today. Okay, we do have a question from Stephanie, who sent the basketball flower. And that is, what are some questions patients should be asking to their docs about their HCM treatment? All right, you want to take that?
So, patients should ask about, will this affect my life? Will this affect what I should do or plan for my life? And so they should ask that. And different patients will get different responses depending on how risky their disease is, and if it's in fact impacting their heart in a substantive way, or they may have to change on rare cases, they may have to change their careers or their lifestyle to accommodate their disease. They should also be asking, assuming they don't know if they're at a center of excellence, they should be asking, how many patients do you see? How expert are you with this disease? Those are questions that all patients should ask for any disease, but certainly for this one as well. And then I think a big question is, what about my family? How do I protect my family? And I think if there's one thing we need our patients to help us with, it's how to approach their family and how to make sure that we increase the circles of our catchment so that we protect as many people as possible. And then finally, they need to be asking questions about, do they need, what types of therapies do they need to treat their cardiomyopathy, and what is to be expected in their individualized disease course.
And if a doctor says to them, I've seen somebody like you once before, it was about 5 years ago. If that were you as the patient, what would you do?
Well, I wouldn't wait for a response. So I mean, it's just like you have to treat this disease as cancer or other diseases. If they saw one lung cancer every 5 years, clearly they don't have a lot of experience with this disease. One of the challenges for hypertrophic cardiomyopathy is that in medical school we get the basics of it, and many physicians have not really pushed themselves to continue to understand this disease, and so they operate under the impression that they can just treat them medically for years and years and really not notice the problems that are accruing. So if a patient hears that, really they should do their own investigation, best one being calling you. And I think if patients tell me that, I usually will refer them to you just to get the lay of the land on how to empower themselves as a patient with this disease. Yeah,
so if they're here watching this on Facebook or YouTube or on our website, they've probably already gotten the memo. So we're going to require a little bit on that one. But if you have a family member who thinks that their local cardiologist can handle this just fine and things are getting a little bit more complex, you may want to encourage your family members to get to a higher volume center. And thankfully now we have them around the country, so most people should be able to get to them with limited inconvenience.
Right.
So
The other thing we do is that, yes, you're right. If they tell me that there are two kids, or one is in some other state and the other one another state, usually we will have someplace locally they can go to. But if they can, most patients come home, quote unquote, or they congregate in one state for the holidays. And so what we typically do is we'll time their screening echoes and their visits for when they're here for the holidays. And that's one way for them to approach their family members to get this done once a year. And that really works well.
we've actually even had families go to like family reunions and all go together, and they schedule it so that they can go to the center like a day before or a day after a family event, and they can all get the information together. So we have another question from Kathy, and the question is, do people ever get a second myectomy? And the answer is yes, but let's discuss some of the reasons as to why.
Yeah, so myectomy should not ever happen a second time, but things can happen. And so what would happen in a first myectomy that might prompt a second surgery? Well, if you start at the early age, when they're young kids, sometimes they have a second one because the heart is still growing. But that's not a fault of the surgery. That's a progression of disease. In middle life or later in life, the heart is usually not continuing to thicken. So if there's a failure of myectomy, it's really that they did not appreciate the amount of muscle that needs to be resected that is contacting either the mitral valve or the papillary muscles or the contralateral wall of the LV, causing further obstruction. So that's more of a issue with understanding what is everything causing obstruction during the case, so that in the operating room they can address all of it. The other times I've seen myectomy fail is if there is more problem with the mitral valve that was not addressed, perhaps. And this is one of the things you talked about in the disagreement among surgeons. So we have to fine tune that. But sometimes there can be some intrinsic disease of other valves that, if it's not addressed, might continue. But the myectomy itself is usually a failure of inadequate resection. And having done a bunch of them here now, and we're watching all of these in the operating room, it's very clear that you have to micromanage exactly the area of resection and really test in the operating room after the procedure, before you leave the operating room, that it's all been taken care of with different medications, for example. I've had a few patients, not here, that have come to me for alcohol ablation after myectomy, and we've done them successfully. We don't want to be doing that. That is a failure of myectomy in a patient who either refuses or can't really go under the knife again for myectomy because of the risk. But in almost all those cases, it's because a little bit more distal in the septum was not resected. And so we can then use alcohol ablation to fine-tune that one spot, but it's not ideal, as you know.
Yeah. So the short answer is most myectomies. Now there's a couple that, you know, we've had really great high volume surgeons do them, and over the course of time the anatomy shifts a little and the geometry of the ventricle shifts a little bit and the obstruction does reoccur. These are really rare. But if you do need a second one, in most cases they were done by a non-expert in the first case, a novice. And you kind of want this done by an expert, because they're opening your chest, they're opening your heart, they're doing the surgery. You might as well go to the best one first. Another issue that we work with payers on to help them understand that if you don't do it right the first time, you're probably going to be paying for a second one.
Yeah, it's a big one.
Now, Kathy's asking another question, which is a little bit complicated. Does HCM ever turn into asthma?
Oh, I like that question.
Yeah.
So one of the things I tell patients about asthma is that asthma is typically a disease of the young. It's a specific allergic reaction with specific pathology. When you get older and you're diagnosed with asthma later in life, it's almost always, unless it's an asthmatic form of bronchitis from smoking, it's almost always congestion. It's almost always what we call pulmonary edema, which is, even if it's transient, irritation of the lungs due to the backup of blood there, even for a moment, can cause asthma. It's not really asthma. It's a bronchospasm or a spasming of your lungs because it's being irritated. And there's many patients who have that, and it's a sign to me that really the hypertrophic cardiomyopathy has moved into a different stage where they're getting into congestive heart failure. People oftentimes don't realize that hypertrophic cardiomyopathy is a form of heart failure in some patients, and it can be patients who then get congested secondarily. And anytime the lungs are in jeopardy with that, they will get an asthmatic component. They will hear wheezing. And they may even go to lung doctors and get all kinds of inhalers and steroids and things like that, and jump up and down and say this is all lungs. But I highly encourage that you work on the heart, because if you work on the heart and improve the function of the heart, many, many times, I think in the majority of those patients, the asthma goes away, implying that really this was all heart failure. And it's actually pretty miraculous when that happens. And you only know to do that if you see a lot of patients.
Exactly. So a lot of patients with hypertrophic cardiomyopathy were previously diagnosed with athletically induced asthma or other forms of asthma because they get short of breath a lot of times with activity. So the best way we have found to help rule out whether it's true asthma or not is a pulmonary function test. And that pulmonary function test can rule out what's going on with the lungs or rule in what's going on with the lungs. And if you've been told you have asthma and you are on albuterol and you also have hypertrophic cardiomyopathy, it is highly encouraged that you get a really good pulmonologist and a really good HCM specialist. We do have a couple of people who do need true albuterol inhalers because they have severe asthma and hypertrophic cardiomyopathy. But that is a very dangerous line, and you'll want to make sure that you're covered probably with a defibrillator, because the albuterol can make your heart race. Right. And you want to make sure you've got something to cover you for that. So it's a tricky balance. We're going to ask one more question, and then we're going to kind of wrap things up here in a few minutes. So are there any limitations with exercise for patients with hypertrophic cardiomyopathy?
So that's a great question, and that's a evolving question, because there's increasing research that exercise in some regards, certainly, and at certain levels is very healthy. However, historically, there have been limitations because of the fact that in some patients, the aggressive or high-intensity types of exercise can stimulate adrenaline, which can also stimulate arrhythmias, and has been associated with sudden cardiac arrest in some patients, even though the majority don't have cardiac arrest who are athletes, or or even the majority who have arrest are not athletes and not doing anything exertional at the time. The combination of high exercise in this disease can be a setup for that. So there's been guidelines and multiple things written about this. In general, what I tell patients is that exercise in general is good to remain fit, to remain healthy in terms of your body size, because that interacts with how your heart is functioning as well. But there are certain rules that you really shouldn't be doing any competitive athletics. You shouldn't be doing what we call burst activity, where you're going 0 to 60 all of a sudden, this big adrenaline rush. Those are probably out. And in general, if you can exercise and still carry on a full conversation without really breathing heavy, that's probably a level that balances the healthy milieu of what you can get out of exercise while minimizing the risk. And so these are not guarantees. There's no guarantees in life. But if you do those things, and it's a work in progress, many of us feel that's sort of a balance that allows you to stay fit and keep the risks in check as well.
And I will take this opportunity to plug the study Live HCM. First of all, I'll tell you that we are going to have an upcoming broadcast on Live HCM with two of the other principal investigators, Dr. Rachel Lamper and Dr. Charlene Day. It's coming up in about 2 weeks. And what is Live HCM? It's a study looking at 2,200 patients with HCM over a 5-year period and tracking their activity level. And I say activity level because we want everybody involved from the ages of 8 to 60. We want to track what everybody's doing. Whether you're, playing pickup basketball with your buddies, whether you're going to the gym 3 times of the week, or whether you're watching Family Feud at night. We don't care what you're doing. As long as you let us know what's going on, then we can track what your heart's doing, what your heart rate is doing, and what your symptoms are. So it's really important that we get as many patients as possible in that group. I will put a special call out for the 8 to 30-year-olds group. We really need some more population in that age group. But we're going to be putting a special call out, and you'll be able to hear all about the study and what's going on, how many we've got in, and where we think it might be leading us in a couple of weeks. We do have one last question I will pop in here real quickly, and that is Kathy wants to know, what about oxygen assistance? Is there a need for oxygen in hypertrophic cardiomyopathy as a therapy?
Yeah, really, it's not something that comes up as often because typically it's not a problem with the oxygen levels. You can have patients who have a combination of problems. You may have patients with severe chronic bronchitis from smoking or other problems of the lungs that then develop or have hypertrophic cardiomyopathy, and so you might get a component of hypoxia there. But really, it's not something that comes up that often, because in and of itself, the hypertrophic cardiomyopathy does not cause low oxygen levels, and giving oxygen to someone with hypertrophic cardiomyopathy is likely not going to make any improvement in their symptoms.
There you go. Well, we appreciate all your wonderful questions today. There were some good ones. Hari, any final thoughts or points before we sign off today?
No, I mean, the final point is I'm very excited. You know, I'm very passionate. I'm very excited about what we're building here. I think we do a phenomenal job. I'm very proud of the team. A good team is one where if I'm not here from day to day or 1 day or 2 days or even a week, it still keeps going and it still gets the highest quality care. I think we have that here. And it's the first time I really feel that way. So I'm very proud of that. And from top down, from administration down to everybody who's on the ground floor with these patients. Also very thankful of you, Lisa, for 15 years working with me, whatever it is. It's a long time working with me to really and helping guide me to make sure that this program can be as good as possible. So thank you.
Well, you're very welcome, and we're happy to have you on board as a hypertrophic cardiomyopathy Hypertrophic Cardiomyopathy Association recognized Center of Excellence, and we look forward to watching the program get built up and seeing how many patients that you can treat and manage and help us raise awareness and maybe even change some legislation in the state of New York so that we can get more people to get baseline evaluations in their GP's offices.
Yes, yes. Thank you.
Thank you very much, and thank you all for signing in today. And you can rewatch this later on, and you can pick it up on YouTube in the next day or so and share it with your friends and family who aren't Facebookers. Thanks, Dr. Naidu, and have a great day.